Good afternoon, everybody. Right, thank you. Good afternoon, everybody. Welcome to our Academy of Consultation-Liaison and Psychiatry Journal Club. Today, I have Dr. Aniruddha Deka. He is an assistant professor of psychiatry at Rush University Medical Center in Chicago, where he serves as the medical director of Transplant Psychiatry. Dr. Deka received his medical degree from Guwahati Medical College in India and completed his psychiatry residency at Rush University Medical Center, following which he pursued his fellowship training in consultation-liaison psychiatry at Yale School of Medicine. His clinical work focuses on consultation liaison and transplant psychiatry with expertise in the psychiatric care of patients across the transplant continuum. He is also actively involved in medical student education and serves in the leadership roles in pre-clerkship and clerkship training. So everybody, I welcome Dr. Deka to present the Journal Club. And for the audience, if you have questions, please type them in the chat box. I will look at them and I'll ask about it to Dr. Deka. Dr. Deka, the dais is yours.
Thank you, Dr. Nagaran. Can you see my slides?
Yep.
Okay, perfect. Well, good morning, everyone. Good afternoon, depending on the time zone. Thank you for being here for the Journal Club today, and we'll be focusing on depression in solid organ transplant recipients. And I will be anchoring my discussion around this special article, which was published in 2023 in the JACLP, ACLP Best Practice Guidance on Evaluation and Treatment of Depression in Solid Organ Transplant Recipients, authored by Dr. Zimbrian and colleagues. So taking a look at the landscape of transplantation, in 2025, according to UNOS, which is the organization that maintains the transplant wait list and tracks a lot of data relevant to transplantation, solid organ transplantations, over 49,000 transplantations were performed. And this was a record annual number, and it seems like every year this number continues to increase. So there's a large and growing population of folks who are receiving transplantations and living longer. If we look at the prevalence of depression among people who have received transplantation, the range, as you can see, is quite wide. It's anywhere between 5 to 75%. And also, even if you look at the different organs, the range remains quite wide. For lung, it's a little bit more narrow, but that's probably because of the smaller number of studies. Regardless, it does seem that the prevalence can be quite high. Why this range is high, it's difficult to know, but probably because of different instruments, different thresholds being used to measure depression. So the standardization is not quite clear. And if you look at how many US transplant centers offer dedicated mental health services, it's less than 38%. So we have a large growing population with possibly a large burden of depression, and the infrastructure to care for their psychiatric needs is not really keeping pace. Taking a look at the clinical impact of post-transplant depression, there is a 65% increased relative risk of mortality associated with post-transplant depression. It's also worth adding that there's evidence suggesting that transplant recipients who have had their depression treated, their survival rates were similar to people who have transplant recipients who've never been depressed. So it seems that this signal is being primarily driven by untreated depression. The other factors or impacts of post-transplant depression include graft dysfunction, increased healthcare utilization, issues with adherence, particularly immunosuppressant adherence, which is quite critical for graft maintenance in the post-transplant population. There is also higher rates of unemployment after transplantation in people who have post-transplant depression, and quality of life and other functional outcomes can be worse. Now looking at the article itself, so this was a special expert consensus article, and the guidance came from the ACLP Transplant Psychiatry Special Interest Group in collaboration with the Guidelines and Evidence-Based Medicine Subcommittee of the same academy. This is the first practice guidance specifically addressing psychiatric disorders in the post-transplant setting. Previously, most of the guidance has been in the pre-transplant setting, and this seems to fill a gap not addressed by other guidelines. The aim of this consensus report was threefold. One was reviewing the literature on screening, evaluation, treatment, and impact of depression in transplant recipients, offering clinical guidance and identifying research opportunities, and supporting the Academy members, ACLP members, in providing care and advocating for clinical and research resources in CL psychiatry and transplantation. So taking a look at this on the left side, you can see this pyramid. A lot of you may be familiar with this, showing levels of evidence. At the top, you can see systematic reviews and meta-analysis, which is essentially the highest level of evidence. Below that comes randomized controlled trials, then cohort studies and observational studies, then case-controlled cross-sectional. And at the base of the pyramid, you see expert consensus. And this may include things such as modified Delphi processes, which is a process that this article used in formulating the expert consensus. So it's important to note that in transplant psychiatry, particularly in the post-transplant phase, the top of the pyramid is kind of sparse and empty. There isn't a lot of high-quality randomized control trials. For example, there's only one RCT for an antidepressant in lung transplant recipients. So in these kind of situations where literature is not there and trials are difficult to structure, expert consensus using these kind of methodologies can help fill the evidence gap. And the modified Delphi approach, as we'll see subsequently, is an appropriate methodological choice for these kind of situations. So this is the process that this study used, and it had 5 phases. First was the systematic literature search across 6 databases, which ran from January 2000 to December 2020 and yielded more than 12,000 articles, which was narrowed down to 146 for analysis. Then there was formulation of a writing group for drafting some of the recommendation statements. And this was constituted with 8 experts, 7 physicians, and 1 PhD psychologist, primarily drawn from the transplant psychiatry special interest group. And they formulated some recommendation statements, which were then sent anonymously through a survey process to 35 other experts who would sort of comment on consensus, whether or not they agreed with the draft recommendations. Now, step 4, which is highlighted here, which was setting a priori threshold for consensus. So 80% consensus threshold was set here. So any statement which fell below the threshold was excluded. The writing group then interpreted the results, and the statements were accumulated to create a clinical algorithm. And finally, there was an external review by the ACLP board and guidelines subcommittee, ultimately resulting in approval of the guidelines and then subsequent publication in 2023. So looking at the recommendations, the first big recommendation is screening. So all adult recipients should be screened for depression. That's one of the recommendations. And it should be first at or before 6 months post-transplantation, and then again before 12 months, and then there should be an annual screening indefinitely. Now, why indefinitely? Because the psychological burden after transplantation does not resolve after the first year. A longitudinal study showed the need for mental health services actually peaked between 6 and 12 months. And then another study showed that depressive symptoms continued to affect mortality in recipients as far out as 10 years post-transplantation. Now, looking at the instruments that you may use for screening. So according to the consensus statement, the one tool which had 100% consensus among the experts was one of the PHQs, whether it's the 2, PHQ 2, 8, or 9 item version. And it's been validated against some standardized interviews for depression in heart transplant recipients. One of the advantages is that these are fairly brief. So the 9 can take 5 minutes, the 2 can take a minute or so. Another option could be the hospital anxiety and depression scale, which has been again validated against structured clinical interviews. One of the advantages of this is that it does not rely on some of the somatic symptoms, such as fatigue and appetite changes, which can often overlap with post-transplant recovery and can inflate scores. There's also the PROMIS 57 or PROMIS 59, which has been validated in kidney transplant recipients. The second recommendation is what to do after a positive screen. So if there's a positive screen, the first thing is that if the patient is already in mental health care, then the results of the screen should be communicated to their provider. If there isn't a provider, then there should be a clinical evaluation for depression. Based on the key principle that screening does not equal to diagnosis. PHQ-9 score alone cannot drive treatment decisions. And as we discussed, sometimes scores can be inflated by somatic symptoms. There was also a recent JAMA Psychiatry article showing that many patients don't fully understand what the PHQ questions are asking, whether they're about frequency or severity of symptoms. So there's a little bit of ambiguity there. A evaluation can be helpful in sorting that out. Then the second part is about heterogeneity in depression. They may not all have major depressive disorder. There can be adjustment disorder, demoralization, and the treatment can differ depending on the specific diagnosis. The other thing is there was an 83% consensus in terms of who should be seeing these patients. And there was 83% consensus that somebody with transplant familiarity or expertise is preferred. And this makes sense because a lot of patients carry medical comorbidities. There can be immunosuppressant side effects, and there are certain transplant-specific experiences such as grief, survivor's guilt, difficulties with body integration that may come up. And if you're unfamiliar with transplantation or with psychiatry in the medically complex, that might be missed. Finally, if community integration. So with transplant centers casting a wider net geographically, many patients are living far off from their center. And if they're receiving care in the community, it's important to sort of communicate with the mental health provider if they're in the community. The third recommendation is regarding medications. Some of the key prescribing considerations that were recognized by the consensus, expert consensus were drug-drug interactions when making decisions about medications. This held 100% consensus, which makes sense because there's a lot of CYP interactions with the immunosuppressives, particularly tacrolimus. Other factors were safety, tolerability, medical comorbidities, patient preference, and the risk of graft damage. Then first-line antidepressants were also stated by expert consensus, and they were escitalopram, sertraline, and mirtazapine. The first two had 100% consensus, and mirtazapine had over a 90% consensus. Makes sense again because all three have fewer CYP interactions. And then escitalopram has favorable tolerability and has been widely used in medically ill. Same with sertraline, has been studied in the SAD-HART trial, established safety in medically fragile population. And then mirtazapine seems to address insomnia, anorexia, and nausea. And these are all things which are common in the post-transplant phase. This study didn't really analyze the rationale behind these choices, but they did note the likely reasons why these agents were preferred by the experts during their survey. The least preferred by consensus were MAOIs, tricyclics, and fluvoxamine. Fluvoxamine, important to note that it's a strong CYP inhibitor and can dramatically increase tacrolimus levels, which can subsequently lead to nephrotoxicity as well as neurotoxicity. The fourth recommendation covers psychotherapy. So there are certain transplant-specific issues that are particularly amenable to psychotherapy, things such as survivor's guilt, role changes, beliefs around adherence, and then some people have external locus of control, and then grief associated with donors passing. So looking at some of the factors which should be considered before referral, according to the consensus, the first two, which had 100% consensus, was cognitive ability of the patient to engage in therapy and availability of therapy. So a lot of times in the post-transplant period, due to various reasons, where there's delirium, encephalopathy, some side effects from immunosuppressives, they may be cognitively limited, and therapy may not be as helpful. Same with availability. If there isn't a therapist that the patient can see, then a referral wouldn't really be helpful. Some of the other factors which should be considered, evidence of efficacy, physical ability of the patient, and patient preference. The survey did not really inquire about specific therapeutic modalities, but they did cite this meta-analysis of 14 studies which tried to see what's the evidence for different modalities. Interestingly, dynamic psychotherapy had the strongest signal with 4 out of 4 positive trials in kidney recipients, though they didn't have any positive trials for liver recipients. CBT, which is usually widely used in patients with comorbid medical illness, there was 1 positive trial in kidney recipients, but no clear benefit in liver recipients. Supportive psychotherapy, again, mixed pictures, same with mindfulness training, where there is a lower number of studies and depression is inconsistently assessed. The next recommendation is about prevention of post-transplant depression. And this has direct implication for not just post-transplant, but also pre-transplant evaluations. On the left side, there are some of the key risk factors for post-transplant depression, which includes pre-existing depression or mood disorder, which is really important. Some of the others are substance use, poor social support, steroid treatment, female sex, some psychological factors, as well as severity of medical complications. The headline for this recommendation is that it is really important that the leading intervention should be treating the pre-existing depressive disorder before transplant surgery. It does seem that pre-existing depression is a very important predictor of post-transplant depression, and it makes it particularly important to try to treat the pre-existing depression. So in the evaluations side, it becomes important to recognize it and not just provide recommendations for or provide candidacy assessments, but also recognize the depressive disorder and provide recommendations for treatment of the depressive disorder. Other preventive interventions include optimization of pain control, psychoeducation about some of the things that people might encounter post-transplant, such as survivor guilt and steroid effects on mood, which can help people prepare for that and not feel sort of shocked that they are experiencing that. Addressing comorbid substance use, encouraging physical activity, coping skills, improving social support, and addressing low self-esteem. Now, future directions which were recognized with this consensus statement included access and availability of mental health services, treatment efficacy, research through randomized controlled trials of antidepressants and psychotherapy, looking into pathophysiological mechanisms behind post-transplant depression, implementation of mental health care within the transplant workflow, as well as telemedicine. It is worth noting that the literature review that this study did was only up to 2020, so the evidence base around telemedicine has likely evolved, and that'll be something interesting to look into in the future. So this article proposed a clinical algorithm for depression in the recipients, and this is a simplified version. A more complex version is in the article that you can look at. So the first thing is that there should be ongoing prevention and psychoeducation, both in the pre as well as post-transplant phases. And it should be constantly in the backdrop, and it should not be a one-time intervention. And then screening, as we talked about, should be at 6 months, 12 months, and then yearly thereafter. And a positive screen should trigger the first decision point, which is whether the patient has a mental health provider, in which case you should notify the clinician. If there is no mental health provider, then that should lead to a clinical evaluation for depression. And if a depressive disorder is diagnosed, then we should move to treatment planning. And it could be psychotherapy or pharmacotherapy, depending on some of the factors that we discussed previously. And oftentimes they can be considered simultaneously if the patient can engage. If there is an embedded psychiatrist or a psychologist, then treatment should start there in the transplant clinic. If there isn't, then this should be referred to the community for mental health resources. Again, sometimes people may live in rural areas with limited access to mental health care. Then a collaborative care approach can be employed with the primary team or the transplant team treating depression, but aided by asynchronous consultation with a psychiatrist. Now, looking at the strengths and limitations of this study, on the strengths side, this was a first of its kind guidance for post-transplant psychiatric disorders, particularly depression. And they utilized a transparent modified Delphi methodology, and they were complying with the agreed checklist, which is essentially a checklist to make sure that expert consensus reports are following strict criteria and are congruent to what be what is the actual reflection of the experts. There was a broad systematic review spanning 2 decades of articles from 2000 to 2020. Then it was an expert group with a median of 14 years of transplant experience. The practical clinical algorithm is easily applicable to practice and can be sort of disseminated with the transplant clinic. And then it does address all major organ types and it has a multi-center perspective. Coming to the limitations, we talked a little bit about the lack of grade A and B evidence, essentially lack of randomized controlled trials or limited randomized controlled trials. The group was again self-selected from the primarily from the special interest group, transplant special interest group of the ACLP. And these are only MDs and PhDs. There's only one PhD psychologist. It did exclude some other clinicians who may be treating depression, such as social workers. Then depression is a heterogeneous entity. It could be MDD, adjustment disorder, demoralization, but the guidance sort of treats it as a single entity and limits diagnostic and treatment specificity. The survey response rate, as we discussed, was 60%, which is not bad, but still leaves it open to being influenced by individual respondent preferences. There wasn't any organ-specific recommendations. Population was highly heterogeneous, and then limited data on telemedicine and newer agents as well as interventional agents. So I'll leave you with 6 key takeaways. So screening is important for all the recipients with PHQs at 6 months, 12 months, and then yearly. Positive screen should be referred to a mental health clinician with transplant familiarity for evaluation and treatment. The first-line antidepressants recognized are escitalopram, sertraline, and mirtazapine, chosen for safety, tolerability, and limited drug-drug interactions. Psychotherapy, we should consider the cognitive and physical ability and availability when referring for psychotherapy. And then treating depression before transplantation is very important. It's a very powerful preventive intervention, which had 100% consensus among all the experts. And then we're talking a lot about the lack of resources and how people may have to be referred to the community to providers who may not have familiarity with transplantation. And CL psychiatrists can actually have a central role and help fill the gap, can advocate for resources, and also help integrate into the transplant centers and teams. So that's all I have for you. Thank you very much.
Audience members, if you have any questions, please place them in the chat box. We don't have anything yet. I have a question for Dr. Deka. Talked about screening in the paper. Who has the ownership of that screening, if it's positive, or who does it?
Yeah, that's a great question, and I think the consensus statement, the expert consensus, doesn't fully provide guidance on that. And I think with the post-transplant care, there is a lot of monitoring of patients, primarily on the medical side with the transplant teams. And the easiest way to integrate screening would be with the regular transplant visits. But that would require integrating yourself with the transplant teams and being able to push through the recommendations that we have and educating all the personnel, including the MAs, to appropriately employ the screening during the time periods that we mentioned. It does make sense for psychiatrists to take ownership if, for example, the screen is positive, then to provide recommendations in terms of where should the patient go. Should the patient be evaluated by the psychiatrist if they're embedded within the transplant center, or if there isn't embedment, and then possibly referral to a community center or doing a collaborative care approach.
Thank you. We have a couple of questions in it. There's three coming in. The first question is, does the impact of morbidity and mortality only include depression diagnosis after transplant, or does depression diagnosis prior to transplant also impact morbidity and mortality?
So I think the research on that is not very clear, but what we know is that depression, pre-existing depression, is a high risk factor for post-transplant depression. And the other part, which is a continuation of that, is that post-transplant depression, if that happens, which is again highly likely if you have pre-transplant depression, which is untreated, can lead to all of these problems with elevated mortality and morbidity. And then this one study which demonstrated that if you're able to treat the post-transplant depression appropriately, then the survival rates, particularly the mortality, is similar to people who have received transplants but never had depression.
Thank you. The next question is a little bit of ethics and research. You mentioned the lack of randomized controlled trials. Is this something that can be solved? Are there other trial types for these patients that might work so that we are not withholding beneficial care?
Yeah, so I think agree with the ethical problems arise. Definitely, I think we can have randomized controlled trials with active comparator groups, especially if you're looking at different types of psychotherapies. But yes, it's definitely difficult to do it with a placebo in these kind of situations where there is a high risk of morbidity in the post-transplant phase. And that's where some of these types of studies, where there is real experience in the community of a lot of people seeing patients who have lived with depression post-transplant or have experienced depression, and we can draw from their expertise and formulate some clinical guidelines. And I think this article fills that gap. Some of the other things which can come beyond sort of randomized control trials could be, open label trials. It could be things such as drawing from case reports, case series. But yes, I think it is difficult to formulate randomized controlled trials, and oftentimes we have to rely on expertise for treatment decisions.
Yeah, a couple of questions, and we should end by then. Should a transplant procedure be deferred for patients with pre-transplant untreated major depressive disorder?
Yeah, that's a great question, and that's often something that comes up. So I think it depends. Not all depression should preclude transplantation, especially if the patient is agreeing or is going forward with the recommendations. Now, as we know, depression is not something that's going to be treated really fast, but we do know that adherence and ability to engage does correlate with response to treatment. And adherence is another factor which is really important in the post-transplant phase. So if somebody has mild or moderate depression, that may not be a contraindication or is not really a contraindication transplantation, especially if somebody's engaging in treatment. Same with severe depression. Even with severe depression, if they're still able to engage in treatment, if they're able to follow recommendations and are concomitantly, a lot of times I would suggest psychotherapy or starting a medication, but that doesn't mean that I would say that they're a very high risk to the point that they should not be listed. It's just that we should continue monitoring that they are engaging with the recommendations that have been provided.
They also should have the capacity to make the decisions.
That is correct.
This question is from Sandra Akimoto. She is a RN case manager and a nurse practitioner. Her question is, given that solid organ transplant is high dollar, would it not be best practice to include these evaluations on all transplant patients. Center of Excellence criteria include psychiatric, psychological support, that is transplant, bariatric, and cardiac device placement. I believe that this includes a futile care evaluation as well.
Is the question about
including the evaluations on all transplant patients?
Pre-transplant, or post-transplant?
Yeah.
Pre-transplant. Yeah, I think it's part of the guidelines framed by UNOS and OPTN that transplant people who are being evaluated for transplantation should undergo a psychosocial assessment, but it does not really clarify who should be doing the assessment. And most of the time, the assessments are done by clinical social workers with specific, questionnaire tools. A lot of people use SciPad, etc. And it depends from center to center, but essentially, according to UNOS, you definitely should have a psychosocial assessment. It just does not specify who is doing the psychosocial assessment. In our center, for example, social workers would do the primary assessment, and then if there are certain factors which trigger a higher sort of level of assessment, then they would be referred to the psychologist or the psychiatrist for further assessment.
Are you able to take two more questions?
Yeah.
Okay. What is the greatest barrier in your opinion for why more transplant centers do not have integrated mental health service for post-transplant care?
Yeah, I think that's really interesting because you would think that it's with all the resources that transplant centers have, it should be easy to integrate mental health care. But unfortunately, I think is that there's a lot of moving pieces with different types of specialties, because transplant, even though we're considering it as a homogeneous entity, we are dealing with many different specialties. It could be hepatologists, it could be nephrologists, it could be pulmonologists, it could be surgeons. So with everyone, when you're discussing and trying to figure things out, different people may have different thresholds in terms of recognizing importance of mental health treatment. But yeah, I think that is one of the big barriers, trying to interact with many different specialties and trying to get them on board. And I would also say that this is relatively new, providing mental health care in the post-transplant. Historically, it's always been pre-transplant evaluations, but now that we have a rising volume of patients getting transplanted and seeing rising volumes of depression, I think this will become more and more important, getting embedded mental health treatment within the transplant centers.
Final question. In regards to making their own decisions, how does this work in pediatrics?
I am not a child and adolescent psychiatrist. I think this would still, I do not want to speak as an expert on this, but I'm assuming the question is about consent. I think this would still be a combination of medical necessity and consent from parents. But again, I'm not an expert in pediatrics, so I defer that question.
All right, we're at 1:04 Eastern time, so we'll stop our journal club here. Dr. Deka, thank you very much for your presentation. It was awesome. And for all of the audience, also thank you to you for asking all the questions. I hope everybody has a good day and a good weekend. Thank you.
Thank you very much.